He may not be painful, he may not even know that he's got a cancer.
What is colon cancer?
The small intestine is nearly 22 to 23 feet long, and the large intestine is about 130 to 140 centimeters. In the UK and in America, colon cancer is quite a dominant cancer. Another red flag symptoms is unexplained weight loss. Preventive measures are much more needed than screening and diagnosis.
What sort of preventive measures one can take? They can put it into their daily habits. You probably are making decisions that will change lives. How does it feel?
We are humans. We make mistakes. I can confess, I don't deserve an applaud.
Does it have anything to do with inner strength, spirituality?
For me, it's total surrender. That's where your Dharma comes in.
Please explain. For Gen Zs,
There's something called natural course of the disease. Identify your body. The large intestine starts lower right side and goes all the way up. Left side comes down into the back passage. There's something called gene therapy, one of the upcoming treatments.
would it be given to the person who is already affected?
It's not that simple.
Is it pure science?
It is pure science, but again, you're trying to play God. You can never get there. 100% guaranteed.
This podcast is very special. It is special because we are trying to combine science and spirituality in dialogue with someone who has excelled in both science and also spirituality. He is Deputy Director of Postgraduate Medical Education, colon cancer surgeon, and as I said, he's also spiritual practitioner. Dr. Ashok Puligari, welcome to Soul Sync.
Thank you very much for inviting me.
How are you today?
I'm very good.
And there is so many things to unfold, and I'll try to do that as part of this conversation, both on the science side, which is your expertise, and also your spiritual side. But before we get into that, please share your experience both in science and also your thoughts on spirituality.
I'll try not to use medical terms because I believe the podcast is going to be watched by many people who may not be in the medical field. Colon is a term used for large intestine. So you have a digestive system which starts from the mouth and ends up in the back passage. So from mouth through the gullet, which is called esophagus, and then go into the stomach. And at the end of the stomach, it's the small intestine. And at the end, last part of the gut is the large intestine. And in medical terms, it's known as colon. The small intestine is nearly 22 to 23 feet long, and the large intestine is about 130 to 140 centimeters. So colon cancer is the cancer of the large intestine. It's not a very common condition in the eastern part of the world, so that's why you don't hear much about it. It's more common in the Western world, more common in the Caucasians, white population. It is second commonest cancer in UK. The breast cancer is the most common cancer all over the world, including UK. Prostate cancer, you would have heard a lot about it because that's the most commonest cancer in men. That's why you would have heard a lot about prostate cancer, which is universal. It's just not restricted to UK. But in UK and in America, colon cancer is quite a dominant cancer.
So, if we were to start from the symptoms, what symptoms does the affected person would get if they are in any stage of, for initial stages, let's say in the initial stages of colon cancer?
So red flag symptoms are bleeding through the back passage, seeing blood when you go to toilet. You see blood, fresh blood in the toilet. It may be just coming as just blood or mixed with the stool, or it can come just beginning and at the end. Every person has got a various way of describing that. So bleeding is one of the red flag symptoms. The other symptom is change in the way you go to toilet. It's called change in the bowel habit. So bowels in the medical terminology is going to toilet. So for example, most of the Asians, they go to toilet at least once a day. But that's not as common as in the Western population. So going once a day for you is common. For some person, going once in 2 days. Some people go once in 3 days. And there are quite a few people in the Western world, they go once a week. That's common for them. So any change to this normal pattern is called change in the bowels. So for example, you're going once in a day, but suddenly you start going 3-4 times a day. Another person goes once in 3 days, but he's going every day. So that change can signal some change in the large intestine.
Yeah, few things to dissect and maybe
Yeah.
put it in a very simpler terms. When you say the back passage, we are looking at stool, we are looking at poo.
Yes.
And the other thing you said is not the normal way of bowel movements,
Yeah.
right? Which could be due to having something different that you normally eat, especially your spicy food, as we see. So for the viewers and for the simple person to understand and not confuse and misunderstand between recurring stool movements with the potential risk of colon cancer, is there any other symptoms that they may need to look at? Because it can be easily confused. So someone has had a different food which they normally don't have, and they got diarrhea. And I think sometimes it's possible through some other reasons they may have a little bit of blood as well. So not to scare people to start with, and then to provide them with information on what the specific things that they need to see. Is it a pattern that they need to look at in terms of symptoms, how long it happens? Or is it just that, once it happened and then they have to go for screening, which I will get to in a moment?
Yes, the common things are common, uncommon things are uncommon. That's why it's called uncommon. So food and medication, they both have an impact on your emotions. Okay. Some foods cause you go more frequently, as you rightly said, spicy food or mostly food eaten outside, street food, they can cause you go more frequently. And there are some food which can cause you constipated. Mostly sweets where a lot of clarified butter, which is called ghee. When you eat a lot of ghee or a lot of red meat or a lot of meat without eating enough vegetables or salad, you get constipated. That's common. And the second commonest cause of change in the bowels is medication. If your doctor has started on some new medication, some of them cause more frequent stools, or some of them cause less frequent stools. So less frequent is constipation, more frequent is loose motions.
Now, if you need to tie that to see the risk of colon cancer, what's the difference? Is it the blood in the stool? That's the alarming thing for one to go for screening, not just the recurring or constipation of bowel movements. Is that the right assessment?
As I said, these are the symptoms. It doesn't mean
Yeah.
that you got cancer.
Yeah.
Even if you're passing blood every day, it can be due to various other reasons. Simple things like hemorrhoids, which is called piles in common terms. So that can cause bleeding. There are various other conditions which affect the large intestine, which can also cause bleeding. But there is a certain age when you actually start worrying. If a person 30-year-old or a 40-year-old is passing blood once in a while, I wouldn't be thinking of cancer in him. But if somebody is 60 plus, I would be more cautious in saying that it's okay. It may not be okay unless we prove that he hasn't got a cancer. So if there is a reason you can explain that your bowels have changed because of the food you eaten or medications, then that's okay. But everything is normal. You haven't changed your diet. You haven't had any new medication. You haven't been to a different country where you go to different countries, like many people traveling from Western countries to India or Turkey or Africa, they get infections, viral infections or bacterial infections. It's called diarrhea or dysentery, secondary to local infections. If that's not the case, you have not gone anywhere, you have not changed your diet, you have not taken any new medication, but your bowels have changed. So that's where the suspicion comes in. That's when you start doing tests. Another red flag symptom, very significant symptom for most of the cancers, is unexplained weight loss. If somebody is losing weight without planning, well, as you know, nowadays fitness is quite important for people. They don't want to gain weight, they have to be fit and active. So they do a lot of exercise or yoga or dieting to make sure that they are not becoming obese, in the sense they are not becoming fat. But if there is unexplained weight loss, you haven't done anything, you're eating as the way you should normally eat, but suddenly you notice that you lost weight in a very short span of time. That's the concern. So that's another symptom
Sure.
you need to be
Sure.
cautious about.
You mentioned about the age groups. That probably would be more worrying to have those symptoms. In terms of colon cancer, which age group is most at risk to get this, and which age group is less likely to get it?
Anybody less than 40, it's very uncommon. But in the recent past, we have noticed that more younger people are being diagnosed with bowel cancer. But still, it's not a disease of young people. Though the incidence of young people getting bowel cancer has increased slightly, it is still a disease more common in 60 plus. So in the UK screening program, that's where it usually starts at 50. So Scotland has got a different age group and England has got 50. But I think overall it will finally boil down to anybody 50 plus will have regular screening. And anybody who's 60 plus, if they start developing symptoms, which I mentioned earlier, that needs further investigation.
How is in UK you mentioned that people over 50 there is regular screening, but how is it in the Asian countries? I know you mentioned at the beginning that it's the numbers are less in that side, in that part of world, but in terms of screening, I don't think the Asian countries, because of their health system, they don't have the regular screening. So what is your recommendation for people outside of these Western countries? Do they need to regularly schedule their screening over 60 or over 50?
Because the incidence of large intestine cancer, which is colon cancer, is not very high, it may not be as useful as it is in UK or America. In India, the most commonest cancer is oral cancer because of smoking and chewing tobacco. It is very obvious and very common. That's the commonest cancer. And lung cancer is overall the commonest cancer in the world. So lung cancer is very dominant. So I'm not surprised that India, China, Japan, they don't screen for bowel cancer. But I think in the last 2 decades, the number of colonic cancers diagnosed in the Southeast have also slightly increased. But still, the oral cancer is the most dominating cancer in India. In countries like Japan, stomach cancer is more common. So they have a much more intense screening program for stomach cancers in Japan. And the methods are so specific, they can diagnose the stomach cancer when only few cells are affected. So that's how specific and intense they are. So screening program are relevant to the incidence of the cancer in that particular country. So that's why I'm not surprised that it's not there. I think places like India or Southeast Asia, preventive measures are much more useful, they're much more needed than screening and diagnosing.
You touched upon preventive measures. I want to dive a bit more into it. What sort of preventive measures one can take to help themselves from lessening the risk of, you know, getting colon cancer? Is there anything that they can do so that they can put it into their daily habits?
Most of the cancers are genetically based, but there are some risk factors for every cancer. It's evidence based, it's based on statistics. For example, smoking is a risk factor for lung cancer. That doesn't mean that person who does not smoke will not get a lung cancer. He might still get a lung cancer. A person who smokes, it's not necessary that he will get lung cancer. But people who smoke, they have higher incidence of lung cancer. So similarly, for colonic cancer, red meat is one of the well-recognized risk factor. The composition of the red meat and the changes which happen in the red meat does have an impact on higher incidence of colonic cancer. That's why it's more common in UK, I suppose. But that doesn't mean that people who eat red meat, all of them will get colonic cancer. It's not like that.
Yeah, we're not scaring people who eat red meat. Yeah.
They are at a higher risk. But it's mostly pre-existing genetic makeup of a person. If there are family history of cancers or family history of, there are other conditions which are high risk for colonic cancers.
Is there any other dietary things one should consider to again, lessen the risk of colon cancer?
Well, as I said,
apart from red meat?
red meat is one of them
Yeah.
for colonic cancer. And then what they say is there is something called high residual diet and low residual diet. So high residual diet is more roughage, so which keeps your bowels regular. Low residual diet is very high in protein and less in vegetables and fruits. So high residual diet is more healthy. It doesn't prevent cancers or it doesn't promote cancers. Similarly, low residual diet is not very healthy, but that's commonly consumed by most of the bodybuilders. They eat a lot of protein and less veg. But I think things are changing now. People are aware that eating fresh veg and boiled vegetables should be a part of your regular diet. So, as I said, dietary modifications are useful, but it is not proven that by making dietary modifications, you will not get the cancer. You may reduce the incidence, but not completely abolish it. As I said, because most of the cancers are genetic based. Environmental changes does have effect. Smoking is one of them, well recognized. People think smoking promotes or is a risk factor for lung cancer, but it has got effect on every organ in the body. Every organ in the body. You will be surprised. So there are some factors like that, and dietary factors. As I said, Japanese used to eat a lot of spicy food. That's why the incidence of stomach cancer is higher in Japan. For us in India, because we eat a lot of tobacco and smoking and alcohol, oral cancers are more common.
So you touched upon the dietary things. In that, I want to take your view on ultra processed food. Do you think that has any effect or risk factors that will increase for colon cancer specific, but generally any other cancer?
There is a specific mention about microplastics, which has been well recognized as one of the risk factors. So it's something new which we were not worried about 50 years ago or 40 years ago, but that's not the case anymore. So processed food is unhealthy, and it is a risk factor for many things. So I would not recommend processed food on a regular basis at all.
I wanted to check your memory on your stats. How many surgeries you might have done so far as part of the
Surgeries, well, we used to keep account when we were training, but I would say it'll be in thousands,
thousands?
thousands. Yeah, yeah,
Thousands of surgeries. Okay,
yeah.
so that takes me to spirituality side of it. You've done thousands surgeries, or thousands you said, sorry. What is it like to getting into the operation theater? One is your experience, hands-on, but there's something else that you're dealing with. It's not like, anyone in the entertainment world, getting in front of camera and doing something. It's not like software job sitting in front of computer and working. It's about dealing with human. And you probably are making decisions that will change lives. How does it feel?
Very responsible, and it is very intense. When we talk to the patient about any operation, we tell them about what it involves. We also tell them about the complications associated. We are humans. We make mistakes. It's normal. But people don't expect us to make mistakes. So when we tell them about the complications, they ask, what are the chances of me getting that complication? So we always try to tell them, based on the previous records, this is the percentage of complication in this particular operation. So 6%, 10%, 5%. But when it comes to individual, if it happens to him or her, it's 100%. So for them, it's 100%. So then my stats won't make a difference to him.
Absolutely.
You said it's 6%, but it has affected me. So I'm that one of the 6%, but that means it's 100% for you. So every individual patient responds differently. And every single operation, whether it is small or big, it is a life-changing event. It has an impact. Our intention is to make them better, but sometimes it doesn't happen the way you expect it to happen. Things can go wrong, and things have gone wrong in the past, and I'm sure no matter how experienced you are, things will go wrong. That's the part of my job, and my intention is to keep trying my best every single time I get into theatre. And it's not about just me, it's a teamwork. There is an anesthetist, there is an assistant surgeon, there are nurses, there are people who are looking after the equipment. So it is a teamwork, but there's always a captain. So being a surgeon is like being a captain of the ship. You are responsible eventually for everything because it's your patient.
There is so much that you said, but I want to pick on two things straight away. One is when you said we are human beings, doctors are also human beings, and you said they do make mistakes. And these mistakes could be catastrophic for the patient, absolutely for the patient. But patient side of things probably world knows because it's there for the world to see. But doctor side of things, maybe no one even knows what they go through. They think that's what I gave an analogy of a software employee, an entertainer, standing in front of camera against the doctors. What goes through you? You know that you have done everything the best you can, but it didn't turn out the way you expected. How does it feel for you that particular day after you come out of the operation theater?
I have had many sleepless nights, I can confess. Even if I have done my best, if I have a feeling that I could have done better, I can't sleep. until that patient fully recovers and goes back home. So it is extremely challenging. It is extremely difficult, especially when you are well aware that you may not be successful in this particular patient. You know that this may not end up as a good outcome, but you still have to do it because patient wants it and the family wants it. But eventually, the outcome has an impact on the family and the surgeon.
That's science.
There's absolutely no doubt about that.
That is science. Now, the healing process. One for you, because obviously you have to go back again. Again, you have to do the same thing with a different patient. How is the healing process for you when you come out of that situation? One. And two, how do you train the patient or the family around that patient straight after that surgery? So if you can break this down into two parts, first starting with you, what is the healing process for you, if there is any, and then obviously from the patient and their family members.
Well, as far as the patient is concerned, I operate, God heals. I'm not a part of the healing. I'm only a technician. I have cut something or stitched up. After that, it's the God. It's nature. I am not a part of that. So that's not in my hands. But doing it the way it should be done is what matters to me. And as far as healing, my healing is concerned, it's an ongoing process. And it can never be the same, or it can never be different in a way. Each individual family is different. As I said, for them it's 100%. They've lost a son or they've lost a father. It's a permanent loss. And I'm a part of that. I have been a part of that. Even with the best intentions, if I have done a procedure and outcome has been bad, what we try to do is to give them that information starting from before the operation, through the recovery, and towards the end. There is something called breaking bad news. It's an extremely important part of our training. We all do that. And as I said, no matter I have to do that, every time I have to do that, it is extremely challenging. Meeting people, family, daughters, sons, and seeing them going through that emotions that their family member has been diagnosed with a cancer and he's going to have an operation and he may die. Not at all easy for them. And for us, I have to take a stance with the expertise. As long as I do my job efficiently, there ends my bit. And after that, as I said, what happens is nature, natural course of the disease. There's always a natural course of the disease. If you do operation, what will happen? If you don't do operation, what will happen? We always tell them, we always give them options. So some of them, they do take the option of not doing anything. They say, I know I got a cancer. I'm 86 years old now. I had a good life. I don't want anything. Just let me live as it is. And we respect that. And we give them that choice.
So your healing process, I think you touched upon it and you said that it's a process, that it's ongoing process. Can you give more detail on that, a bit more on what that process looks like?
Well, as I said, I have had many sleepless nights when things have gone wrong or things are challenging. As long as I know to myself that I have done the best I could, I cannot sit and continue to be in that state of mind because next day I have to do something else. Next day I'm seeing another patient. Next day I'm doing another operation. So I have to park that and go with a fresh mind, with a fresh attitude, with a fresh determination to do the job again. There's no end. So, in a way, we don't fully recover. We manage our emotions, we manage our suffering in a way to make sure that that doesn't have an impact on what I do next. If I'm in a state where I am not able to do my job, it's better not to do anything, take time off. And most of my colleagues, they do that. They take time off for months, 2 months, 3 months. They say, I can't cope with this anymore. So they take a break and they come back after 6, 7 months or 5 months, whatever time it takes.
Does it have anything to do with inner strength? And you know where I'm going with this? Spirituality.
It does have, every person is different, you know. Every person reacts to a particular situation in a different way. So it's individualized. To have that inner strength and the confidence to come back and keep doing the same thing again and again does need a personality. It's a type of a character. Not every doctor who has done MBBS, all of them, they don't become surgeons. Some of them, they very clearly say, I'm not made for it. So they choose other specialties. So people who do surgery, I think there is a recognized type of people who take up surgery. Majority of them, not all of them. So you have to fit into that category to do that job. So most people say that surgeons are actually very arrogant. It's a well recognized opinion. It's called type A personality. So they are the boss. Even people say they've got God complex. They think they're God. But that's their opinion. But as I mentioned earlier, we are human beings. We make mistakes. And when we make mistakes, we go through that patch of suffering and depression. And the sooner I come out is better for me, because system needs us. I'm sure you know there are not enough doctors, but there are more patients. More people are getting older, more people are getting cancers. So it's difficult. It is extremely challenging, but that's the way life is.
Okay, I think we touched upon the sad side of it. So I want to uh, look at the happy side of it, where you know I'm sure there must be loads of those moments. But how does it feel where you went into the operation theater and you did exactly what you want to, and sometimes it actually turned out even better in terms of the operation, and maybe following on from there, the recovery as well. Share some moments like that with us.
Well, majority is like that, fortunately. So we do see families and patients coming back to us, thanking us, giving us thank you cards and appreciating our contribution. But we don't allow that to get to our head, because appreciation is their virtue. So they are feeling happy for what you have done to them. But for me, it's a job. If I don't do my job properly, I don't deserve an applaud. Even if I do my job properly, you don't need to applaud, because it's a job. I'm getting paid for it. So that's the way I look at it. I have to make sure that I do this properly every single time. So I'm not doing it for appreciation. I'm not doing it for people to applaud me. But if they do it, it's kind of them. It's nice of them. But I will never allow that to get to my head. and it doesn't make me any stronger or weaker.
You literally reminded me of something from one of the movies, Bollywood movies, Munna by MBBS, where I think the Bommarina Irani stands as a dean and something says along the same lines. But I want to try on the spirituality side of you. So please tell what spirituality means for you. Just define in your own way, because there is multiple ways people practice spirituality. One through religion, one through finding their better version in a way, finding inner strength, etc. But what is your version of spirituality?
The For me, it's total surrender. Your existence is not because of you. Your existence, physical existence, is determined by your parents and by their parents and their parents. If you keep on going up and up, eventually it's the Paramatma. That's where it all started, and you are a byproduct of that lineage. So your existence, physical existence, is doesn't mean anything. So you have to be thankful and you have to be grateful to your parents and your ancestors. And as I mentioned, the eventuality is Paramatma. He's the first person. He's the starting and he's the ending as well. So if you understand that whatever you do, whatever opportunity you are getting in this physical world or in this material world, it is because of him. And you have to have that faith and that obedience to say that it's only because of you, nothing else. And having to dedicate everything you do to Paramatma is the only way. Otherwise, you wouldn't be sitting here and asking me these questions if you were not born. Your existence in this material world is a gift from him. So there's nothing to be proud about. All that you need to be is ever so be grateful and ever so be thankful for giving you this opportunity by Paramatma.
You touched upon two things. One is surrendering, and the other one is Paramatma. What do you mean when you say surrendering? Who you think one should surrender, and how, according to you?
When I say surrender, that means you are not taking the ownership of doing things. You have been given that opportunity to perform that. It means I have done surgery. No, I haven't done surgery. God has picked me to be in that position, to do that job. So he is making me do that job. I am not doing it. Having a skill, doing a procedure is the physical aspect.
Science.
That is science.
Yeah.
But after, as I said, after I do the surgery, how is it heals? How does it heal? It heals because the way the body is built. And how is body built? So he's the one who has given you that life and a form, physical form. No one can do it. Can you create a human being? Can you create a life? You cannot. So he is the one who has created you and he is the one who has given you that opportunity. So everything you do, good or bad, you're accountable for it. You're responsible for your actions, but the opportunity is only given by him. So you decide. And if you do what needs to be done, that's where your your dharma comes in. So what is dharma?
Please explain.
Every individual has got different roles. You are a son at one point, you are a father at a different level, you are a brother. So your attitude and your behavior with your brothers and sisters is different, with your children is different, with your parents is different. So you have got a responsibility, a role to play. And as long as you're doing it in the righteous way, the way it should be done, that means you are attempting to follow that dharma. There's no English translation for that word, unfortunately.
Consciousness?
No,
No?
there's no English translation. So you can put it as righteousness in a subtle way, but that's not what it is. If you are a father, you have a responsibility to look after your children in a particular way. If you're not doing that, that means you're not following your dharma as a father. And as a son, there are different roles. So same individual behaving in a different way in a different roles. Why is that? Because that role demands that. That's the creation.
Sorry, I have to interrupt you because we started from surrendering and Paramatma, and then we are touching upon Dharma. So, as an individual, I have full faith in Paramatma. I've surrendered completely towards Him, whoever has created the very beginning of life, let alone human life, but any other life. And then comes the Dharma part you mentioned, where again you are like trying to do your role as whatever capacity that you are in, as a father, son, whatever. How do you correlate to all of this? It's, I mean, in a simplest form, if possible, so that, this is more for the Gen Zs who sort of understands it through the word of spirituality and but doesn't really get it, because there are so many theories, as we know. Everyone does it in their own way. So in the simplest form, if you have to like put it all together and give that helpful information for the viewers, what would that be?
I'll give an example. There'll be 40 children in a classroom, starting from year one. They all have the same teachers. They all have the same subjects. And at the end of 10 years, when they do the exams, do they get same marks? No. So every individual has approached that 10 years in his own way. Theoretically, everyone should get first class. But that doesn't happen. So that means it's your responsibility, your attitude, your way of looking at things has changed the outcome.
Yeah, that's a great analogy that you've drawn on that one, and I'm sure it'll really help to connect and understand what it exactly means. I want to slightly switch back to colon cancer now, to see, in terms of the list of cancers and in terms of curability, where does this stand? So let's say top three. I'm assuming that especially in the Western world, in the men it's prostate cancer, and the women it's breast cancer, and then probably which one, colon cancer is the third one. One is it, so if you can tell how many of them can be cured in what stage, so that again it's going to be informative for the viewers to understand if they are in a certain stage, they don't need to worry, they can still be curable. If you can provide some information on that.
There's something called natural course of the disease. Every disease has got a pattern. Every disease has got a natural course. So what we are trying to do is we are interrupting that natural course to prevent further damage. So the outcome, or in medical terms, it's called prognosis. how many people will actually get cured, how many people are going to die. This is based on the statistics. The outcome is based on the stage of the disease when it is diagnosed. First time you go with the symptoms, we do tests and we identify, okay, this is where we are.
What are the normal stages in colon cancer?
So there are various classifications, medical classifications. I'll simplify it to say A, B, C, D.
Four. Yep.
A, the chances of survival are up to 90%. So the disease is very localized. So you do whatever needs to be done. There's something called 5-year survival rate. That's how it is measured. Anybody who is diagnosed with any cancer, once the cancer is diagnosed and they started the treatment, after completing the treatment, are they still alive after 5 years? That is called 5-year survival rate. So the 5-year survival rate is very good for stage A. Stage B, up to 50%. Stage 3, up to 30%. Stage D, less than 10%. But this is all based on statistics, and every individual responds in a different way to the treatment. It's not the same. The treatment methods are the same. Treatment protocols are, they're all certified by the guidelines, the Royal College guidelines, Cancer Society. There are several recognized official kind of nice guidelines. There are set rules you have to follow, and then when you do that, some cancers are very aggressive, some cancers are not. There's something called histology. It's again a medical term. What it means is the actual microscopic nature of the cancer. That's called histology of the cancer. So in colonic cancer, most of the cancers belong to one particular type of histology. Those cancers, all that we have mentioned now, is more relevant to that particular type of cancer, majority of them. But there are about 30%, 20 to 30%, they don't fit into that particular type of cancer. They are different types. So their prognosis and their outcome is not the same. They're different. Some people die very early, actually, because the nature of the cancer, the histology of the cancer is different. The microscopic structure is different. The way they behave is different. And as I said, staging of the cancer, whether it is localized, whether it is spread to other parts of the body. Sometimes by the time you diagnosed, you must have heard people said, it's already spread to your lungs, it's already spread to your liver. So that means it automatically reduces the life expectancy and the outcome. So the chances of you having a complete cure of that surgery or the treatment is less.
I know you mentioned that it differs from person to person how quickly it spreads. And can I use the word tumor?
Yeah.
The word localization that you said. So if it starts from large intestine, if I'm not wrong, right, the tumor, and generally, I know that differs from person to person, you mentioned it, but generally for a normal person, how long does it take to spread more parts of the body so that there is a lesser chance? Is there a timeline, or again, it differs to person to person?
Differs from person to person and differs with the location. As I said, the colon is nearly 130 to 140 centimeters. So if you identify your body, the large intestine starts on the right side, lower right side, and goes all the way up. From left side, comes down into the back passage. So majority of the cancers are in the last 30 to 40 centimeters of the large intestine.
That's quite long.
Yes, it's called rectal cancers or sigmoid cancers. That's the medical term. So, in simple terms, the last bit of the large intestine, just before
The
coming
passage.
passage, is the commonest area, and then that's nearly 60%, and rest of the large intestine is kind of individualized. Again, left side is more common than the right side. In the right side, just where the small intestine finishes and the large intestine starts, at that spot again is more common on the right side. That's about 12% of the cancers. So 60 and 1270 is finished, and rest of the colon, it shares the rest of the bits. So overall, I would say 60 to 70% are on the left side and mostly towards the end. So right side cancers spread less than the left side because of the location. The lower the cancer is, the more chances of spreading locally because of the location itself. And the spread is, it can directly spread, like coming out of the intestine, going into the other tissues. It can spread through the blood because it's all connected. There's something called lymphatics, lymph glands,
Lymph nodes.
lymph nodes. So it can spread through the lymph nodes. And there's another method which is probably difficult to describe in simple terms, but it can spread all over the abdominal cavity. That's another
And
one.
how long does it take for a person to know the symptoms? And the other thing I was going to ask you is, how painful would it be for a person who's going through that symptoms in terms of physical?
It may not be painful. He may not even know that he's got a cancer. You will be surprised. Some of the patients who come, first time we see them, and we know that it's already spread to the liver and lungs. He doesn't even have any symptoms. So it's very personalized. But most commonly, when we identify, it's usually localized. And the other thing which has an effect is, because it involves the large intestine, if it has gone through the large intestine and it has burst, so that's an emergency. Patient comes in emergency and you have to do an emergency operation. So when that happens, instantly, everything what we described before goes out of the window.
So it's immediate surgery.
Immediate surgery, and the prognosis is worse compared to diagnosing it before the emergency happens and actually treating or doing an operation or whatever treatment you have to do.
On that particular example, what symptoms the patient would feel when it bursts out?
We'll have severe, sudden abdominal pain, unbearable pain. He will start vomiting and his tummy kind of distends, it starts bloating up. You will know within few hours that he's not well.
And
Even a common person will understand that this is not
normal.
This is not normal.
But in the other example that you mentioned, that the person might actually have that in their body, I'm saying colon cancer, but they may not have any symptoms.
No.
Is there any way that one can do the screening for them, apart from the regular screening that, in UK, over 50, people are regularly scanned? Because you mentioned that it is less in under 40, but it is less. It's nothing like, it's not there. So is there anything that they can see as a symptom? I don't want to scare people that, is, as I said at the beginning, regular bowel movements, etc. But is there any, key thing that they can take away and say, this is an alarming thing. I need to go get screening.
Yeah, as I mentioned, the red flag symptoms,
Yeah.
those are the symptoms you should be worried about. There's no harm in getting checked, even if you're 40, if you've got those symptoms. As I said, the incidence of younger people having bowel cancer is slightly increased nowadays, but not to scare everybody. This is all based on evidence. There's a national record. So every cancer which is diagnosed goes onto that record. So with that, we exactly know the age of the person, what treatment he had, how long did he survive, when he died. Everything is available. It's open. You can go and check anybody's record on the internet. So based on that, 50 seems to be quite reasonable age to start screening, not before that. Unless there's a family history of certain conditions where you have to start screening in very young age, starting from 12 or 13. So there are a few particular conditions where there's a family history of those conditions. Then that's different. So as I said, you start screening at 13 and 14, and you have to do the test every year. And some of them end up having an operation to remove the large intestine even before the cancer is diagnosed, because they will definitely develop a cancer. So it's called preventive surgery. Luckily, it's very small numbers. It's called familial polyposis. That's the term used. Polyp is tumor,
Tumor.
and it can be a cancer or non-cancerous tumor. So these people who have these polyps, they have hundreds of polyps in the entire large intestine. So it is extremely difficult to keep monitoring and keep removing those polyps. So best thing is to remove the colon to prevent the cancer, because they eventually will develop a cancer at such an age.
Certain point.
Yeah. So those are the only people who have that. There are other few other conditions, few other syndromes, but it's all genetic.
Genetic.
And it's all genetic. So it's all familial. So if parents have that, children are very likely to have it. It's a condition which runs in the families.
How
So
is-
we identify the family, and then we screen everybody in that family.
Yeah, I wanted to touch on that. How is science doing on that? Because the genetical based issues have been so many, not just in this particular one, but also in many other things. But since we're talking about this one, how is science doing on it to revive that? Is there any advancement happen? Where are we on that?
Well, you must have heard the whole genetic mapping has been completed. So the science exactly knows which genes is related to which condition and all those things. But there's something called gene therapy. So modifying that and changing that pattern is one of the options, but that is still at a very basic level. We haven't reached a stage where we can change that. But that has given us a lot of information and a lot of understanding about how these various conditions and syndromes and cancers behave. Gene therapy is one of the upcoming treatments. So we don't know. In future, we may be able to prevent the cancer by modifying that.
So, gene therapy, that particular treatment, would it be given to the person who is already affected, or is it like, I'm just giving an example. My parents have got some sort of cancer, and I'm born. Straight after that, I can be put into that so that I can divert or move away from that risk factor that I may have because of the genetics. How does it work?
It's not that simple.
I just simplified it.
It's not that simple.
Yeah,
As I
yeah.
said, the familial condition which has got where people have these polyps, hundreds of polyps. So that could be an area to look into that, because we know that it's an established condition where it is passed on to generations. So I would assume that that's where the science will first try to make that treatment or make those changes. But I think we are at a very basic level of discussing those options. To you probably will see in movies, but that's not reality. Where gene therapy, gene modifications, and changes, that doesn't work like that. it's still
Is it pure science?
it is pure science, but again, you're trying to play God.
That's where I was going to get to.
Yeah, so
So, I mean, even to imagine that way of science is really fascinating. If it happens, great. But how close it is to sort of challenge, so to say, God, in your words, Paramatma?
nowhere.
Okay.
You can never get there. 100% guaranteed. Science is a part of nature. You can only understand, you can only make changes to benefit the humanity, but you can never be in charge. Never, ever.
Coming from you, those words actually will have a lot of weight. And you know why? Because you change, you make decisions for people completely. It can go either way. It's so uncertain when you're in the operation theater. So, gene therapy, as you mentioned, how many years that it might take even to make a decision that whether it is going to be successful or not? Because as you mentioned, people who is going to listen this will have a certain hope. To be honest, I got certain hope on that one listening from you. But to keep the expectations, what are your views on that?
Well, as I said, we just at the very basic level of understanding the mapping, but how we are going to address, I think extensive research is going on. That's one area where if people are interested in doing medicine and getting into an area where they don't want to deal with the patients but deal with the research, that's one area which is still wide open. We are just scratching the surface.
Great. Thank you so much, Ashok Puligari. It was pleasure. I know we could have touched upon various other topics as well, but this has always already been very informative. I absolutely enjoyed. Thank you so much.
It's a pleasure meeting you.
Pleasure is all mine.